morning, folks. I am Dr. Amit Prabhu, and I am going to cover the anesthesia part of spine endoscopy. As all of you here are surgeons, I am not going to go into nitty-gritty details about the dosages and pathoanatomy and physiology, everything. I am going to stick to a few messages that you can convey to your anesthesiologist that you are working with. So let's start. With respect to anesthesia, the choices that we can offer to the patients are monitored anesthesia care with local anesthesia infiltration, epidural analgesia, and the general anesthesia. And how do we choose the choice? Well, it should be titrated to the needs of the patient and the demands of the surgery. We will be seeing this in the next few minutes. So basically, local infiltration can be used in all transforaminal cases, but compared to epidural, it is associated with more discomfort and hence lower patient satisfaction. So the trick is to limit local anesthesia to a few scenarios like endoscopic lavage for discitis, patients for disc effects, patients presenting with multiple level pathologies and concordant pain where the level or levels of surgery is undecided. Also, transforaminal procedures for upper lumbar or lower thoracic levels can be done under both and are subject to personal choice. I prefer the epidural. For rest of the transforaminal cases, we generally use epidural analgesia. Now for the PSLDs and IELDs, we go with general anesthesia as the nerve root handling can be overwhelming at times for the patient. I am not going to go into details of the general anesthesia as I am sure the anesthetists that you are working with are well versed in it. Here I must mention that we have dealt with quite a few patients that require more than one approach like TFS for a level and PSLD for another. In such cases we use epidural anesthesia with little alterations in the dosages. Now let's take a look at the local anesthetic technique where we use 2% Xylocard, that is preservative free lignocaine. That way we can avoid complications from inadvertent intravascular injection of lignocaine. While the patient is being put in the prone position and undergoing prep, we like to start with our analgesic mix as part of multimodal analgesia. The solution has 1 gram of paracetamol, 4 milligrams of Dexona and 2 grams of magnesium sulfate. We also add Tranexa to this solution to reduce intraoperative bleeding. Midazolam can be an excellent anxiolytic for an awake patient lying prone anticipating all the horrors. But the downside is it takes at least 3 minutes for the effect to kick in and you need to be patient. If you are over enthusiastic with the dose, you may find an unarousable patient at the required time. Fentanyl remains the mainstay analgesic for the local technique. It can be used as bolus dose or as an infusion with intermittent boluses at anticipated times of painful stimuli. Dexmedetomidine is the recent trending wonder drug with roles ranging from analgesic, anxiolytic, sedative and hypotensive agents to name a few. Now the points of interest in local anesthesia technique are, firstly, we need to be aware of timings of most painful stimuli. In my experience, insertion of the dilator and the sheath over it is the most painful part and needs to be well covered with 75 to 100 mics of fentanyl bolus. Also being the most painful part, it can trigger a vasovagal response in some patients. So we need to be aware of that. And the bottom line is we require the patient to be comfortable enough to endure the procedure but also awake enough to flap his feet at us at the right time. Now coming to epidural analgesia where the aim remains the same, minimize discomfort while maintaining the patient's motor control. Usually we place the epidural catheter 2 levels above the surgical site, but this is not a hard and fast rule. The position that we place the epidural catheter is either lateral decubitus or a modified sitting position in which we make the patient sit at the edge of the OT table legs hanging down and feet supported by a stepping platform. The usual sitting position traditional sitting position that we use for spinal anesthesia with legs extended and a rounded back can exacerbate pain and worsen the disc herniation and hence avoided. Now the epidural bolus that we use is 12 to 15 ml of 0.1% bupivacaine or ropivacaine with buprenorphine and or fentanyl as adjuvants. Finally, it's my sincere request that you use an epidural catheter rather than injecting the bolus directly through the Tuhi needle. This catheter can be removed at the end of the surgery. Now let's get down to the juicy part, the problems and complications that we have encountered during our adventures with the scope. Firstly, intolerable pain due to the primary problem. At times, the pain of disc pathology is so severe that the patient is unable to move, let alone lying prone on the OT table. For such patients, analgesics should be started preoperatively. We generally prescribe buprenorphine patch and NSAIDs for such patients. Fentanyl doses may also be needed to be titrated upwards to help position such patients. And lastly, epidural analgesia can be an excellent option in these patients. Now, as we discussed earlier, sudden pain can trigger the vasovagal reflex, and we have had many first-hand experiences in such cases. So, it needs to be watched for and managed appropriately. Coming to a complication related to the epidural, the accidental dural puncture while accessing the epidural space. With dural puncture, we are left with two options: either abandon epidural and continue with a local option, or put the epidural catheter at a different level, and if you decide to go with this, then you must restrict the bolus to 4 to 6 ml of 0.5% preservative-free lignocaine to avoid motor blockade. I had previously stressed on using an epidural catheter. Well, if this were to happen when we were using a direct bolus technique through Tuhi needle, we would have ended up injecting 15 to 16 ml of local anesthetic solution in the subarachnoid space, resulting in disastrous total or high spinal anesthesia. So no cost cutting there. Please use an epidural catheter. Another complication with the epidural, motor blockade, despite using 0.0625 to 0.1% solutions for epidural. This is not very common, and we have observed this in 6 to 7 patients only till now, with no long-term sequelae in any one of them. Firstly, it occurred in patients with severe canal stenosis, and secondly, the block wears off in 20 to 30 minutes. So what do we do now? We do administer IV methylprednisolone 1 gram to start with, and then we can either withhold the surgery and wait and watch for the block to wear off, or we can proceed with the decompression. With all our patients, we went ahead and performed decompressions, and by the end of it, the patients have recovered power in both their feet. Now, there have been studies that suggest that epidural space lavage with the irrigating fluid may have helped to wash away the local anesthetic, explaining the recovery. So, all said and done, don't let these problems scare you. We have discovered that spine endoscopy is highly satisfying and very rewarding. So that's it, folks. Thank you for your attention. Hope you have a great and memorable journey ahead. Thank you.
So, one question. Do you use, any kind of continuous infusion with the epidural, or just
No, we give the bolus at the start of the surgery, and that's it. It's done in the one bolus only. If the surgery is extended, we keep the catheter, and we can repeat the boluses. Like I said, if there are cases where there are multiple approaches involved. So after the end of TFS and when we are progressing to PSLD, I usually give a denser bolus of around 0.25% bupivacaine or 1% lignocaine, and that covers the nerve handling part of the PSLD. So the catheter helps in that sense. Yeah.
Sir, how to handle and identify vasovagal shock?
No. It's done in this one.
Sir, how to identify vasovagal shock and how to manage it, sir? Because in
Vasovagal
periphery, when
shock
we
is
are
a
working, no one is available sometimes. While giving block, I have seen some cases of vasovagal.
In our centers, we generally have a standby anesthesiologist monitoring the vitals. So basically, if the patient is sweating and has nausea, vomiting, and you can see a dip in the heart rate to around 40s, so that means the patient is having vasovagal. So the first thing that you need to do is stop what you are doing, stop the stimuli, and administer zero point 0.6 mg of atropine. First, look at the BP. If there is hypotension also, then you can administer atropine. Or if you halt all the stimuli, it may return on its own also. So basically, you need to observe that.